Perfect. Hey everyone, we have thanks for joining. We have Dr. C and Dr. An today here. So Dr. C, can you just kick us off briefly? We'll start with some
Sure,
intro and then Dr. An has some slides prepared.
sure. Well, thank you everybody for joining, taking time out of your afternoon today to join. My name's Jaz Zelzala, Dr. Z for short, and I have with me Dr. Jonathan An out of the University of Washington. Today we're going to be talking about two different things. One is kind of an update on an LDN mouse trial, and then the other thing will be rapamycin for oral health. And so those are kind of two of my favorite drugs, my favorite longevity therapies. So I'm excited to kind of present this information to you today. And there is kind of a call for action at the end. So stay tuned. We will be making a request from the audience. That's kind of part of the reason why we have Dr. Ann here today. So let's go and get this kicked off. Next slide. All right. I am Dr. Z, Chief Medical Officer, co-founder of AgelessRx. Dr. An, why don't you go ahead and tell us a little bit about yourself? Oh, I think you're muted.
Okay, is that
There it
working
is.
now?
Yep.
Okay. Yeah, thanks again, Dr. Z. So I'm John. I'm currently an assistant professor at the University of Washington School of Dentistry. So a majority of the time, I run a laboratory that studies the biology of aging in the context of oral biology and oral health. And then a part of my time, I'm actually a practicing dentist. So I see routine patients throughout the day, throughout the week, kind of helping them optimize what I call their oral health.
Okay.
Yeah, so I just put this put this in there, but I mean, so I practice dentistry in a small town called Mill Creek, Washington, called Pacific Northwest Miles, and I kind of do what all dentists do, where we are there to restore your teeth, but also provide you a really good smile. So my practice is not just crowns, but also we do Invisalign or clear aligners, we do implants. So the clinically. It's kind of what I've been doing for the past about 8 or 9 years, in addition to the work and research that a little bit that we're going to discuss later today. So, yeah, I mean, again, Dr. Z, you could let me know, but for this audience, a lot of times, I always like to give a quick background of why a dentist is interested in aging and why, I got into this. And so for me, it just seems too obvious that amongst a lot of the healthcare professionals out there, you kind of see your dentist regularly. And when I was in practice the first few years before graduate school, I quickly realized that many of the things that we are providing our patients is kind of reactive. And so, a filling breaks, we do a crown, a tooth comes out, we do an implant. But nothing was really proactive in terms of not just providing good oral health care, but also kind of dealing with the underlying biology that's changing with his age. And so that's kind of where I got interested in. That's where I did my Ph.D. in. And so I'm still continuing that work here in my own independent laboratory.
So I was going to jump in there. I mean, there's more and more data on the importance of oral health. Poor oral health seems to be kind of connected to a lot of different things, including, increased risk of dementia, increased risk of heart disease, probably increased risk of just premature aging in general, which is why I think poor oral health seems to be, kind of a marker of poor general aging. Do you want to spend just a couple minutes talking about a little bit about like the progression of disease, or are you're going to cover that when we get to the rapamycin information?
I mean, I can just add on to it right now because so it's not just like you mentioned, Dr. Z, it's not just the oral health and oral disease perspective, but actually losing teeth early on may have a significant impact on kind of neuronal censoring, right? So if you think about just the tooth and amount of neurotransmission that happens, right? Think about the bite force that goes to it. Think about the temperature changes. And if you lose all those nerve endings, right, that alone can impact the brain. So I think it's not about maintaining your teeth, maintaining your health, but also maintaining those teeth so that they stay with you for as long as it's possible. So there's direct correlation. And as a field, I think we can do a little bit better in terms of how we can really tell our patients that it's really connected to systemic health. And that's something that we still need to kind of improve upon. But yeah, we could talk more later on when we talk about the rapamycin trial.
Okay, so let's switch. Let's start off by talking about the LDN trial that we've got going on. So just a brief intro for for people who may not be familiar with LDN. So LDN stands for low dose naltrexone. Low dose to differentiate it from the kind of the FDA approved higher dose of naltrexone, the 50 milligram dose that's commonly used for alcoholism. So low dose was kind of discovered as a means to treat conditions related to inflammation and autoimmunity. It's a non-selective opioid antagonist, meaning it competes with opioids for the receptor. And like I said, it's FDA approved for medication-assisted treatment of opioid and alcohol dependence. Brand name goes by Revia or Revia. And when we're talking about low dose, usually its dose is less than 10 milligrams, although some people say this low dose is less than 15. There's no exact cutoff for what low and versus not low, but kind of once you start getting above 10 or 15 milligrams per day, then that starts transitioning between low dose to high dose or normal dose. And then there seems to be two mechanisms of action. One, it seems to be a kind of a direct inhibitor of TLR4, and that seems to have a glial cell inflammation modulation. And then the other is because you're temporarily blocking the opioid receptor, you get this endorphin rebound effect. And that kind of leads to a kind of a positive feedback loop on the endorphin system. And these opioid receptors are found in the GI tract and immune cells. The osteoblast, osteoclast that make up the bones are immune cells, and so it's thought that there is some activity there, and a wide variety of other tissues. I just gave a whole talk through the LDN Research Trust on it was a webinar, it was like an hour and a half long webinar talking about LDN as a potential longevity drug. So if anybody's interested in listening to that talk, you can go to the LDN Research Trust and kind of look for it there. And I'll be speaking about it again in the LDN Research Trust upcoming summer conference. It's an online conference. Let's go to the next slide, Rachel. All right. So the history of LDN. Dr. Bahari. He's I considered him the father of LDN. He noticed back in the mid 80s that HIV/AIDS patients had very low endorphin levels. So he was trying to figure out how to increase endorphin levels. He thought that was kind of the key to keeping them alive. And this was at a time before the antiretrovirals. And so he kind of saw this new drug, this naltrexone had been approved. It had something to do with endorphins. I think that kind of led him to do trials in HIV/AIDS patients. And I think he noticed an increase in endorphin levels. And I think he also reported an increase in survival. But I think LDN kind of fell out of favor once the antiretrovirals started coming on the market, and so kind of interest was lost until I think about 2007, 2009, where you have some smaller studies on Crohn's disease, fibromyalgia. But then from there, I mean, the number of studies has grown, probably exponentially. Last time we looked, this is about a year ago, there's about 230 articles specifically for LDN. There was supposed to be an LDN for acute COVID trial done here in Detroit area. I don't think they ever finished that. And then there was a 2022 trial for long COVID using 3 milligrams a day, and I think they showed some benefit there. And then AgelessRx sponsored a trial combining LDN and NAD for long COVID. We did a webinar about that, so if you want to learn more about that trial, we did a whole webinar about the trial and things like that. But suffice it to say, I mean, if you go to like the LDN Research Trust or one of the other organizations that advocate for LDN, there's a list of many conditions and symptoms that LDN seems to help with, mostly because it seems to tackle kind of two of the biggest issues when it comes to aging, which is inflammation and the kind of this autoimmunity. And there could be others. And like I said, I knew anybody who wants, I go into a lot of depth in this with the recent webinar I did with the LDN Research Trust. Next slide. There we go. There was you want to take this one, Dr. An?
Yeah, sure. Yeah.
Dive into the slide.
Yeah, I mean, since we're kind of on the medical and dental, which I think is one unique thing about this webinar is that, all the kind of the aging parts of this, as well as the inflammation, kind of Dr. Z was mentioning, but LDN, through the word of mouth, at least in my field in dentistry, was still being utilized, very small amounts of it. And I just wanted to present this because this was actually one of the cover pages for the Journal of American Dental Association back in December of 2020, where a group did a systematic review. And so for those who aren't familiar with the term, so systematic review is basically a methodological approach where the authors are gathering or summarizing results from multiple different studies. So in this particular systematic review, they were interested in looking at how dental and medical practices were using LDN to manage chronic pain conditions. And so they poured through, I think, about 790 different articles. They kind of narrowed it down to like 10 or 11 that really fit the rigorous criteria. Some of them were case report studies. Some of them were clinical trials or randomized clinical trials. And they were basically looking at LDN concentrations and what kind of outcomes there were. And some of the chronic pain conditions they were looking at was, like Dr. Z mentioned, fibromyalgia, chronic fatigue syndrome. But in dentistry, there's also kind of oral facial related pain disorders. So there's trigeminal neuropathies, there's chronic myofascial pain, and there's also TMJ disorders. But basically, LDN was kind of, through the grapevines that's been utilized in certain specialist cases to manage chronic pain like TMJ or chronic myofascial pain. And really what this review showed that it could be a good alternative to, what's currently being utilized is, opioids, right? Which, obviously there's addiction issues with that as well. And especially for kind of the older adult population, just managing chronic pain, LDN seemed to be kind of one of the go-tos. And even now I know a few oral medicine specialists. So these are specialists that treat kind of complex orofacial conditions actually use LDN to treat some of their patients for these conditions. But I just wanted to bring this in because LDN, I think there's both medical and dental aspects that are very important, but also beneficial to some patients. So I just thought I'd bring that in.
Yeah, just a shout out here to one of the authors. Her name is Sahar Swedan. She's actually one of our medical advisors. She's a pharmacist here in Michigan. She teaches at University of Michigan. So when I saw this article, hey, look, it looks like a very familiar name. Yeah, so she's a wealth of knowledge. So I'm glad, I think she's published, I don't know, she has her name on dozens of journal articles on a wide variety. So she's also kind of an expert on LDN as well. Let's see. Yeah, so this really kind of highlights kind of like I mentioned before, kind of the wide variety of benefits that are seen with LDN. Here's a study this is dating back in 1983, I think. So 41 years ago, a researcher by Ian Zagan and Patricia McLaughlin. This is a study I think that was kind of largely ignored because it just recently started to get attention. And this is interesting because I think they took three groups of mice from what I remember, and they injected them with neuroblastoma tumor cells, and then they treated one group I think with a high dose of naltrexone, one group with a low dose naltrexone, and then I think one was just kind of a saline control. Is that correct based on what I remember from the study? Yeah. So I think the survival time, if you look at the survival group, is incredible. You'll see that that top curve there, you know, 80% survival on the low dose of LDN compared to compared to the other groups. So I thought that was just amazing in terms of the ability, the potential for LDN to kind of mitigate tumor. It has some kind of protective effect against tumor.
Yeah, if I could add on to there, Dr. Z, I think the other reason why we put this slide in too is kind of this is the basis for where kind of the study that we're doing together, right? So, I mean, like Dr. Z said, this study was largely ignored, but basically what you're looking at is not only the increase in survival, but also there's a delay in tumor incidences. So when the neuroblastoma got injected, they were looking at how fast did the actual tumors develop, and in fact. We try to kind of highlight it up here, but the 0.1 mg per kg daily injection actually not only delayed the tumor incidences or delayed the time before the tumors actually appeared, but it actually increased their survival. But this became kind of I guess, our guidepost in terms of how we want to do the trial. And maybe this is a good time to kind of talk about the trial a little bit before we move on to the next slide, Dr. Z, on why
Yeah,
we want
absolutely.
to do this.
Yeah, so I mean, just a little background on kind of why we decided to, pull Dr. An into this trial is because, we, it's been clear to me for years that I think LDN could be a potential longevity drug, on par with, rapamycin, metformin, acarbose, and some of the other ones. So at first we went to the interventions testing program. We went to Rich Miller at University of Michigan. He helps run that program. And for those who don't know, the ITP is that study on mice. They at 3 different research centers. They give mice treatment. Usually it's either a natural molecule or a pharmaceutical agent, and they monitor, see how long they live. So it's considered to be like kind of a longevity trial for mice, and they do it at 3 different centers at the same time. To kind of reduce the risk of any kind of other variables that can go along with it. So it's kind of become almost kind of like the gold standard for any kind of intervention that you want to look at for longevity. So we made a case to them. It's like, hey, look, we think longevity, LDN is a very good longevity drug. They came back and said, well, the study is on mice, just like the one here, used injectable, and they don't really do injectables at the ITP. So like, well, we don't want to just, leave that be. So said, who else could do a mouse trial on LDN? And that's kind of where we kind of got introduced to Dr. An and his work in longevity in mice through Matt. It was Matt K, right? Matt Keberlin was our mutual connection. So we made a case to him, and we reviewed the data together, and it looked really promising. So we kind of came up with a longevity trial to use in his lab, and that's and that was started. Why don't you give us a little information about like when it was started?
Yeah. So just a quick add into the ITP. I think it's a very, so for those, I just add a few more details of the ITP because I think it's a very important program, like Dr. Z mentioned. I mean, it is sponsored by one of the NIH branches or NIA, and those 3 different sites have what's called a they use what's called a genetic heterogeneous mouse background. So a lot of mice are one inbred strains or just kind of one background, but they kind of combine 4 into 1. And they look at, I mean, here we looked at only 20, but they look at hundreds of animals, control and treated. And just to give you a context, not just how long these studies take at the ITP, but also just the cost that it takes, right? So any older mice that you need to actually purchase can run from $200–300. And so if you think of a couple hundred mice for control, a couple hundred mice for treatment, 3 different sites, just the amount of resources that need to get poured in to test these interventions become very big. And so, coupled with different injection protocols, maybe it wasn't a good fit for the ITP. So Dr. Z and I and others, we kind of gathered around the table and thought, okay, how can we make this work just to see if it works? And I don't know if this is a bad philosophy, but when it comes to these kind of interventions, we want to make sure we do it correctly, but also if we have to fail, we want to fail fast, right? Because as you can see later on, I'll show you some lifespan data, but some of these studies are a year long, right? So if we don't design a robust study from the beginning, obviously that's kind of out the window. Plus, if it doesn't happen really quickly, then we want to quickly move on to other interventions. And so what we actually did was we ordered the animals. And we had about roughly 20 in each group. So one group got a control injection, and then the other group got the lowest dose, like you saw in your previous graph that we showed about the neuroblastoma mice, at the lowest dose of 0.1 mg per kg per day. And again, we injected the animals every single day between the hours of 6 to 8 a.m. And the reason why we did this is, and maybe Dr. Z can explain too, is that the mice are nocturnal. And we wanted to kind of mimic kind of when maybe humans were taking LDN, which was usually at night. So for mice, that is usually in the morning because they're nocturnal. And so that's why we always injected them every day. And we actually injected them when they were actually old. So we didn't do them when they were middle-aged or young. And so that's kind of the design we had. And the other reason why we started them old is that the typical lifespan, the maximum lifespan for some of these animals is usually roughly about 6 months, 8 months, most up to a year. So we would know within a year whether or not this sort of intervention, in this case LDN, would work. And so that's kind of how we designed our study.
So we took older mice. I think was it middle-aged mice? We
took older mice and we started so it's like middle-aged and old. The number of months kind of gets a little it gets a little debated, but usually in our mice they were about 21, 22 months old. Yeah.
So I think we started them at day 500 and something. Right?
Yeah, it's roughly 500, 600 days. Yeah, or okay. 670, 680. Yeah.
Yeah. And so that's about half their lifespan.
Yeah.
Basically. Yeah. Okay. Half the normal lifespan.
Right. The typical kind of the what you would expect with these kind of black sixes. And so
I think only the black sixes are available for as older. You couldn't do this with the strain that they're using at the ITP because they don't have those available to purchase, advanced age.
I think you could get them, but I think logistically it was going to be a challenge too. Yeah. So,
But like you said, we just wanted to try this out. It's like, nobody's really done a longevity trial on mice, so again, we wanted to see, is there any promise here? Are we kind of barking up the right tree or the wrong tree?
Right. And at the same time, because this was kind of new, we wanted to pack in a lot of things that eventually we could go back to. So, not only do we monitor their weight, but also the general health status, but we were collecting blood, looking at grip strength and frailty index, which eventually we'll publish later on. But so that's kind of what we did every 3 months. So
why don't you tell us a little bit about what you're measuring here? I think there's baseline being, when you started before you started the LDN.
Right. Yeah. So with my studies, it, other than looking at their life, like when they die, there's not, obviously there's a lot of biological assays, molecular assays, but whether they are actually correlated with lifespan, we don't know, right? So one things we could do longitudinally is look at something like frailty index, which is an index of about 30 plus measures where you're looking kind of at the general health of the animal. So these are like, sounds, do they respond to sound? How does their fur look? Just kind of like your general physical exam for the mice. But I don't think we have it in the slide, but there is a strong correlation that those frailty indexes correlate with actually kind of the age of the aging animal. So that's one thing we looked at. Obviously, blood we collected just to look at various inflammation markers, if this intervention was going to work so that we could go back. And then we also looked at grip strength, where there is some data to show there's possible correlation. But again, these are some very simple metrics that we could take just to see if there's any effect on there. And then obviously lifespan of when the animals actually die.
Right. Now, just to be clear, I mean, this study is still ongoing. It hasn't completely concluded.
Yes. So I think we put in actually one of the graphs on the next slide. Mm-hmm. Yeah. So what we're finding, and so just for those who haven't seen lifespan graphs, I'll just kind of give you a brief. So this is what you're looking at are male animals, and on the left is their, I shouldn't say probability, I should say percent of survival. So they all start at 100%. And then on the bottom axis here is looking at kind of survival time, and this should be actually in days. And so what you're looking at is every time a mouse dies, there's less percent of survival of those sort of animals. And so if you look at the control animals that have been injected every day, it's kind of mimicking kind of what you would typically find in the black six, normally just kind of as a function of age. But just remember, the control animals were getting daily injection of saline, like the vehicle control. The blue line, what you're actually seeing is the male older animals that were being treated every day with LDN. There seems to be a positive response that some of their lifespan is extending. Now, this study is ongoing, right? So we still have more data points after this. This was a few months ago. And so all these male animals that were being treated with LDN, at least over half of them are still living. And so that seems to be pretty promising in terms of having its more of a lifespan effect. But again, those other markers we're still analyzing. Is this a result of, for example, less inflammation? Is this a result of having higher or less frailty index? We're still analyzing those results. But so yeah, failing fast, I guess it worked because at least the control animals did die within kind of what we're expecting. But now we're in the situation, Dr. Z, where we're just going to have to keep injecting the animals and just see kind of how long they live. And that, that's one of the beautiful things about science is, I mean, just looking at the dose itself, we kind of picked that from a 1984 paper and we just kind of ran with it. I mean, we did some other intermediary level trials with other dosages, but that was purely picked from those scientific papers that we referenced. And so considering those kind of information, I think this looks very promising at this point, at least in mice. Again, I always want to emphasize it's mice, right? So,
Yeah.
but we're still going and they're still living so far. The female animals, we'll have to see at least medium lifespan. There is no effect. There's a few animals that potentially their maximal lifespan might be more, but males, mice, for sure, there's definitely an effect on daily LDN injection.
Yeah. And I mean, again, this is kind of a preliminary trial. I mean, we're hoping that this will lead to larger trials and give us more insights. Just a comment about dosing. I think we kind of glossed over it on slide 9. Richard, if you can go back 2 slide, yep, that one right there. No, two. There we go. So in this study, they looked at I think 3 different dosings. One is 0.1 milligram per kilogram per day. So if you translate that to an average human, let's say the average human is 70 kilograms, that's about 7 milligrams per day. So still kind of within that 10 milligrams or less window we're talking about.
We would still need to factor in the human equivalent dose too, right?
Yeah,
right.
I mean, it's very rough math, but I mean,
right.
On the flip side, if you look at if they took that same dose and they injected it 4 times a day, so they quadrupled the dose, you actually had worse outcomes. So so I think the very first graph that starts dropping off is the 4 times a day injection. So that's a total of 0.4 milligrams per kilogram. So that's 4 times the dose. And then they also did a once a day 0.4 milligrams per kilogram. That's the that's the other one of the other blue arrows there. So you can see that neither one of those groups did nearly as well as the low dose naltrexone. So it's hard to say. I mean, if you extrapolate 0.4 milligrams per kilogram per day to a human, again, not it's just rough math, but that's about what 28 milligrams per day. So that kind of gets you to we're kind of then getting to that higher dose. And just something I forgot to talk about with Dr. Bahari, he was interviewed before he passed away. He passed away a few years ago. He was interviewed, I think, back in 2007 or 2017 about his experience with HIV/AIDS patients, and he tells a story of a patient he had who I think came down with either leukemia or lymphoma, one of the hematological cancers, and apparently the LDN had been kind of keeping it at bay. And then I think there was a mistake at the pharmacy where the pharmacist had started giving him the full dose of naltrexone, and that actually seemed to accelerate his disease. And again, it's an anecdotal, it's anecdotal. I mean, we'll never know for sure whether or not the pharmacy mistake led to this patient's early death, but it's kind of served as a warning that in the case of naltrexone and potentially other therapies out there, it is about the dosing. So again, that's why we call it LDN to differentiate it. So I just want to give that a little bit of background there in case I forgot to talk about that. And I think somebody had asked a question about that as well in the Q&A. So now we can kind of go back. We can go back to the survival curve there. Oh, sorry, you muted.
Oh yeah, so I mean that's kind of the extent that we have the LDN. So I don't know
Yeah,
if you want to just
yeah. So I mean, just for that study, I mean, when all the mice end up dying, when we start having blood markers and other kind of markers that we'll be looking at, we can put all that together in a much more comprehensive webinar and of course a publication. So we'll be happy to present that. This is just a little bit of a preview. So now we're kind of going to jump ship to my other favorite drug is rapamycin. So this was a survey that was done in coordination with Matt Kamerlin and his group at University of Washington. It was I call it a registry. We were kind of asking the longevity community, anybody who was on rapamycin for longevity, to fill out the survey. And I think we also included, I think about 100 or 150 non-users, 172 according to this chart. Because we wanted to gather more data, a lot of people who are taking rapamycin off-label. There wasn't really any trials for it off-label for longevity. We were still running our Pearl trial, and so this is kind of a way to kind of gather some real-world data. I don't want to spend too much time talking about this, but if anybody's interested in learning more, we did have a webinar with Matt Kamerlin back. If you go to our YouTube channel, the AgelessRx YouTube channel, you will be able to find that webinar. It goes back a few months, I think. So if you want to dig into detail with this and other things related to rapamycin, but Dr. An, if you want to tell us a little bit more about kind of what the slide is here for in regards to the dental.
Yeah, I think this goes along with kind of all the other work that we're doing together. So when this was published, we have a lot of other data points. So if people are interested, they could find the article. But one of the things that came up, which isn't surprising, is that one of the kind of the events that happened with people who were taking off-label with rapamycin was increase in canker sores or mouth ulcerations, and then that's very common even for traditional immunosuppressants. But when this topic of canker sores and mouth ulceration comes up, as a dentist, I don't want to sound too, I guess straightforward in that, but depending on what it is, it's not a big deal, right? We know as dentists how to manage it. We know how to treat it, and so we were more interested in, okay, so if canker sores or mouth ulcerations are increased, could we actually do a follow up on this survey and actually go back to those participants that had those canker sores or oral health related impact and actually do a similar kind of a line of inquiry and get some follow-up data. So if you go to the next slide real quick, one thing I want to emphasize is when you hear the term canker sore, it's very generalized, but there are specific terms that describe that type of sore. So one of the common one is just called MIS, which is mTOR inhibitor associated stomatitis. So this is typical for patients going under very high dosages of rapamycin, like a daily dose, a weekly dose, and they cannot just get off of rapamycin or any mTOR inhibitor. And this actually causes not just multiple singular round ovoid types of ulcerations, but they're very painful. And these are the pictures that you see if you were to Google image or whatnot. And this actually requires an intervention, not from a medical perspective, but also from the dental perspective. Traditional canker sores or aphthous ulcers, like just mouth ulcers, is what you would get when you're stressed out, etc. Very similar in kind of looks. And obviously the pain level is not as severe as somebody with MIS. And they actually generally heal on their own. And we could talk a little more in the context of off-label use, but if you go to the next slide there, I have so these are just types of ulcers. And again, I put this up there just to give you an idea. So the panel A, you're actually looking at stomatitis or ulcers from somebody who's going chemotherapy, right? If you're looking at the panel B, that's actually somebody with MIAS. So it looks like just a typical canker sore, but that MIAS is very different from panel D, which is just regular canker sore, right? The pain level in somebody that has a canker sore MIS type of sore in B is really high, right? So presentation wise, it's the same, but kind of the patient perspective, very different. Now C looks really bad, but that's just, it's called a herpetiform. It's not anything related to herpes. What herpetiform just stands for is there's multiple ulcers, right? So this is like, you know, when you got a grand due the next day and you're drinking a bunch of coffee and you're stressed out and you have some other hormonal changes, that's what you get. So all of these are definitely manageable. Even for the chemotherapy one, there are steroid rinses that you could use. But I just want to highlight that the ulcers are very different and the presentation can be different or similar. It really depends on what they're coming from. So we wanted to know more about what these kind of ulcers we're looking at in our off-label users. So this isn't quite published, but I wanted to present it here. If you could go to the next slide. So what we found was that most of our users, so off-label users, expressed that they were getting intermittent ulcers. So what these are it's a combination of, okay, once I start the rapamycin, I get an ulcer and it goes away, or I started the rapamycin and later on it comes and it goes away. But so that's what we define as intermittent. Persistent are users that describe, okay, every time I start the dose, I always get an ulcer, and then the ulcer goes away once I stop the dose. So that's what we call persistent. So what we find is that there's a lot more intermittent ulcers, which is very characteristic. But you know, those intermittent users also typically are at a higher dose, about 6 milligrams or so, right? 6, 7. But what this signifies is, yes, you know, maybe a mouth ulcer is some sort of an adverse event that can't be avoided, but at the same time, it's not severe enough for these users to stop using it. Plus, the concentration doesn't look like it has an impact. So it goes back to the LDN, where I think concentration and dose is very important for any kind of interventions that you're thinking of. The other thing I want to add in, what we did with the off-label rapamycin survey, in addition to this, is we got a chance to actually go back to dental records. And I mentioned early on, you know, one thing unique about dentistry is we kind of follow our patients throughout their life. And so we actually get a lot of records every year. Like if you think about just going to your regular dental office, you get your gum pockets read, you get your dental x-rays, right? So those are 2 records throughout your life. And so we went back and tried to find particular users where we could gather their dental x-rays before they took rapamycin and after, just to see if rapamycin was actually having a detrimental effect or have no effect, right? And again, this is a small cohort. So if you go to the next slide here. So what we ended up doing was, this is a particular case study where it was a 67-year-old male, and he started rapamycin in 2021 at 6 mg per week. And the lines there, we actually use Overjet AI, and this is an AI platform that has been introduced in dentistry that's FDA approved, where the AI goes in there and measures bone loss. And I just put this in there is because what we're finding, at least in this short survey, is that some of those areas, in this particular patient, there was no change. So rapamycin, and they only been taking it for a year, that it didn't actually increase bone loss, but nor did it actually improve bone loss. But bone loss is it's a very weak measure, at least from dental radiographs, because it's 2-dimensional. But the point is that rapamycin is actually not making things worse. Obviously, we don't know the microbiome changes. We don't know the inflammatory changes in those pockets. But running our AI software through all these dental x-rays, what we're finding is that there is improvement. And some of those improvements are very minimal. But the important thing is all those case studies, there's no detrimental effects from rapamycin, at least what we're seeing at low dosages. So this will eventually become packaged. We're still in the review process right now. So hopefully we'll get this published too, and maybe we'll have a separate webinar in addition to kind of everything that we're doing.
Now, one of the reasons why I invited you here today, because you know, for patients who might be on rapamycin, is there a way for them to volunteer their dental data to you, so you can kind of like enlarge the data that you have on this?
Absolutely, yeah. So that's something that we are working on now too with Dr. Z and the group, is that we're coming up with a pipeline for those who are interested, who've been taking rapamycin for a long time, to actually get the dental kind of information to us. And there's a certain process that needs to happen. And it's very similar to if you were moving dental offices. But once we have that pipeline kind of established, then we will be reaching out to everybody to see if they're interested in what we call releasing their dental records to us, and we could have kind of do the similar analysis for it.
Okay. So you anticipate basically, somebody filling out a records release, and then your office can then contact their dental office and say, hey, can you email me or fax me the dental records for the last, whatever, 10, 15, whatever years.
Right.
And then you can kind of, I imagine it'd be useful for you to kind of look at the progression over as long a period as possible, because from what I understand, the natural history of bone loss is, for example, this case up here, there's a 4-year difference there. And so I would imagine, in somebody not on rapamycin, you might anticipate seeing bone loss during those 4 years.
Absolutely, yeah. Yeah. The process is straightforward where you would fill out a form, and it's just like any other when you were moving dental offices where it's your record. So you can release it to our academic institution, and we will have all the protocols in place and security measures in place. And yeah, you're right. I mean, if we have every time point, I guess the more data is always the better, right?
Yeah. So I mean, in an ideal situation, you'd look at somebody's, if they start, in their 30s with kind of the optimal bone, and then over time you see a degradation or bone loss, and then they start rapamycin, and all of a sudden either you see an improvement or at least a stabilization, then that would indicate that we're really onto something here, and there could be a potential benefit for rapamycin, and just kind of give more confidence to the theory that rapamycin has a wide variety of benefits when it comes to healthy aging.
Absolutely, yeah, and definitely will give us more kind of basic data to kind of support larger clinical trials to really evaluate some of these, because they would have to be randomized and controlled. But yes,
how long do you think somebody would need to be on rapamycin in order to start seeing a difference?
So it becomes what sort of difference you want to look at, right? So bone levels, I don't know, right?
Okay.
I could tell you like microbiome differences, even with just the general dental cleaning, you could know within a few months if there are microbiome changes. Specific periodontal pockets, like what is actually happening in those pockets, again, depending on if there are specific markers you want to look at, within a few months, you can notify those changes. And that's actually what we're incorporating with our clinical trial right now.
Yeah, I had now that we're on the topic, I had a conversation with a very well-known scientist in the longevity field. He didn't want to be identified. He told me, he was struggling for years with gingivitis. And he finally, worked up the courage to start rapamycin. He goes back to his dentist, 3 months later. Then says like, "What are you doing?" His gingivitis is pretty much completely gone. Have you seen any cases like that recently?
Yeah, I mean, so not in my practice, but I've had people email me about their dosages that I've been using for gingivitis, even for sometimes for gum disease too. Even in our survey, people would add little notes in their survey, and they would describe how they were struggling with gum disease or gingivitis. And after taking rapamycin, it would actually close off, or it would actually stop bleeding, or I get less gum bleeding. So we have seen some anecdotal evidence, I call it, because I haven't physically kind of been there or seen the records, right? But it's out there. And that's why I think we need to have actually controlled trials to really define this, because if it's out there, I'm pretty sure it's true, because I don't think people are going to be lying about their gingivitis. And yeah, gingivitis is a periodontal disease, or at least gingivitis. Yes, you can improve your hygiene, but if there's some underlying reasons why you keep getting inflammation, I mean, that's something you can't just remove. So yeah, I mean, I have heard of it. I've gotten emails about it. So it is out there. Yeah.
Yeah. So there seems to be something really there. I mean, it's not just, a fluke that,
Right.
this one
Right.
scientist, happened to start it, and 3 months later, as gingivitis happened to clear up. It does sound like there's something there.
Yes.
And I think that's kind of consistent with the survey results we saw. We actually saw fewer issues with like stomach pains and things like that. It's also consistent with, Matt Kaberlin, he's publicly said that, rapamycin has helped clear up his shoulder tendonitis. There was a researcher who we recently had on a podcast, talked about her experience with long COVID, rapamycin, and how rapamycin seemed to,
Right.
almost completely clear up her long COVID
Yeah.
symptoms. So I mean, they're that kind of goes back to the whole canker sore things. Um, correct me if I'm wrong, but canker sores, we're not quite sure what causes it. It doesn't seem to be a virus, for example, but because it seems to be associated with stress, you getting sick, there seems to be something about a shift in the immune system that causes canker sores.
Right.
And I was going to ask you, what's your theory on what causes canker sores, and why do you think rapamycin causes them?
Yeah, I think it definitely has to do with the underlying immune, but that's the part is that not everybody gets those
Right,
canker sores that are
right,
taking rapamycin. So I think it's
sure,
individualized, dose dependent as well, based on that individual. But you're right. Even in the dental field, we actually don't know what triggers these aphthous ulcers, right? And we just know how to manage it. So yeah, I would not. I don't know how, what exactly causes it, but definitely the underlying immune system.
yeah,
There's
yes,
definitely an impact to it.
So yeah, I think it's agreement. We're not quite sure what causes it,
Yeah.
but you're right. I mean, some people say, oh, I'm not getting canker sores, therefore I'm not getting benefit. I wouldn't.
Right.
I would, yeah, that,
No, I would
right.
not. No,
Yeah,
I would
and vice
not.
versa. Yeah,
Yeah.
vice versa. Because you're getting canker sores, I mean, we're not sure one way or the other if there's any kind of correlation
Right.
between
Right.
rapamycin benefit, rapamycin. You showed in that
Right.
slide, the last slide, that it seems to happen across all different doses.
Yeah.
It doesn't seem to be dose dependent.
Right.
Lower doses, higher doses, intermittent, weekly, bi-weekly, things like that. It kind of seems to happen without right now, without any rhyme or reason. Maybe if we had a larger data set, we could look at and
Right.
say, okay,
Yeah.
people in certain age groups with certain medical conditions, there could be some genetic components, but all that's speculation right now.
Yeah. One thing I would say is, like, I wouldn't gauge whether the rapamycin is being effective, regardless of what you're defining being effective is, on based on canker sores.
Yeah,
Because if you're getting more canker sores, that means there is a possibility that you're actually, maybe at least your own system is going into that kind of immunosuppression or actually immune function that you don't want to get into, right? We just don't know, right? So I don't think that would be I would not encourage you to consider that gauge. And if your canker sore gets really bad, your dentist may not know how to handle that. You might actually have to go to an oral medicine specialist. So I would be just cautious of that.
yes, yeah, you bring
Interaction.
up a
Yeah,
good point.
yeah,
So yeah, I mean, when I do prescribe rapamycin, through the AgelessRx platform, if somebody does complain that their canker sores are bothersome, I mean, there are some over the counter, there are some prescription therapies that we can offer. But if it seems to be recurrent and just really bothersome, sometimes adjusting the dose seems to help.
Mhm.
There are some other strategies as well, maybe
Right.
spacing out the rapamycin a little bit more. You're doing every other week instead of every week. So I mean, yeah, using canker sores as a kind of any kind of measurement tool or kind of guidepost is right now premature because we just don't know enough. It seems to be kind of random. But if somebody doesn't counter it, well, and then they're on rapamycin, it's bothersome, like a lot more bothersome than usual. Then yeah, then that's likely an indication that they need to adjust the dose. Not necessarily for any kind of other underlying reason, but just so the person doesn't suffer the canker sores.
Mhm.
Although you're right, it could be an indication that maybe uh it's being something's being overdone.
Right. Yeah. I mean, and there's other interactions you got to think about. We talk about just regular aphthous ulcers caused by stress, but like vitamin deficiency can even cause different ulcers, et cetera. Right. It's just things to consider when you're taking
Yeah.
rapamycin.
Okay.
Yeah.
All right. Now let's jump ahead to the next slide, talking about your exciting trial
Yeah.
that you got going on.
Yeah. So if the listeners or people who are viewing this haven't heard, so we actually got one of the first FDA approvals to actually run a clinical trial using rapamycin specifically for oral disease. And this could be a whole webinar on itself on how to get FDA approval. But for us, we're actually looking at periodontal disease, and the reason why we needed to get FDA approval is because it's a new indication. So we're using an immunosuppressive drug to see if it actually impacts older adults with periodontal disease. So we went through that whole process. It took us about a year and a half. Obviously, it would have been faster if we but there is different parameters that we had to consider, especially being an academic institution. So, but the key point is we wanted to do the trial right, because with this wave of translational kind of neuroscience, I call, happening, whatever data that we generate, whether it's this with Dr. Z or others, we wanted to make sure that it was rigorous and that we had all the right approvals to do this. Because our goal at the end of the day is whatever data we find is to share it with everybody and to hope kind of increase that. So yeah, the trial's happening now. Actually, this past week, we started our screening process. And so we're kind of really busy with that process. It just tells us how much people are interested and how there is a periodontal disease out there that people are still struggling with. And so we're kind of going through that. So, I mean, we don't have to go to the next slide. That was more introductory. But if anybody's interested in learning more about the trial, there's a QR link there. So you could just always go to that. But it's just rapamycintrial.com. And to kind of follow that. And we'll kind of update that website on kind of any data that we find and also recruitment processes in there. So
I can't remember for the life of me, what does RAPID stand for?
oh, it's it's just rapamycin adults with periodontal disease. Yeah, we just call it RAPID, and it's just an acronym. And plus, I think it's it's been a long time coming, and we've been wanting to do this trial for a long time. So we another part of it is we quickly want to kind of get the results out. Again, our whole goal is to see if it does have an impact on periodontal disease, but there's other things in there that we're testing to see how rapamycin impacts. So we're looking at localized inflammation markers. We're looking at biological aging markers. Even if it doesn't have an impact specific on periodontal disease, we're hoping that we just get more information about the biology that rapamycin is impacting. So
yeah, absolutely. I think, you're talking about translational neuroscience. I think one of the most effective ways to do it is start with a disease process like periodontal disease, and then just gather as much information, as wide as information as possible, to understand, the underlying effect that it has on aging in general, the hallmarks of aging and whatnot. Tell me a little bit about the dosing. I remember you telling me about, you're being super conservative in terms of the starting dose. Can you talk about that a little bit?
Yeah, I mean, this goes back to kind of what the FDA would like for us to do, is that currently we don't know the different dosages that impact older adults with periodontal disease. In that disease process, we don't know if 6 milligrams is the right dose, or 4 milligrams, or 0.5 or 2, right? We just don't know. So what we initially need to do is give lots of people various doses of the rapamycin, and basically find that tighter spot of, maybe those side effects are more canker sores. Maybe those side effects are, alterations in cholesterol levels or anemia, right? And so based on those metrics, we will titrate it to kind of what we think is the optimal dose. And at that point, then we'll do kind of bigger randomized clinical trials. But for now, we're just kind of looking at a variety of dosages of rapamycin.
How many people are you looking to enroll?
So each dose, roughly about 10. I mean, it depends on kind of what we need to define. So we do have a safety review committee. And so minimally, we only need like 3 people per kind of dose that we're looking at, all the different dosages, but sometimes we may need more. Yeah, for now, because of the funding that was provided, I mean, while it's limited, we could actually get up to at least 50 different participants. So, but again, it's a slow process. Again, it goes down to making sure that we follow protocol, make sure that it's rigorous. And it's a clinical trial, so we make sure that everybody's safe. And, I have no doubts about that, but still, we have to make sure of that. So,
oh, it looks like we're kind of running short on time.
Oh yeah,
so,
okay.
Yeah. So let's see here. I think we talked a little bit about. Mauricio, can you go to the next slide? We talked about what rapamycin is. I think everybody knows at this point. Hopefully, if not, like I said, look at previous webinars. We talked a little bit about periodontal disease. Yeah, we talked about how periodontal disease, and mouth issues, dental issues. Let me. Did you have anything else to add, or can I kind of jump into the questions for the next?
No, go ahead, jump into the questions. Yeah, let's do that.
All right. So, let's see. First question: is there any benefit in taking less than 10 milligrams of LDN? Like I mentioned before, I mean, so far we think that the 10 milligram or less seems to be the right dose for LDN. Depends on what you're targeting. there's a whole kind of science, clinical, science and art about dosing for LDN. But yeah, I mean, right now the benefit seems to be less than 10, 15 milligrams. So is there any way to evaluate not just longevity, which is a measure of time, but quality of time? I'm assuming you're talking about the mouse trial. So one thing we briefly mentioned that the mice goes through this frailty index, and I think there's like 20 different parameters you're also looking at for quality of life as well for the mice.
Right. Yeah. Yeah. And so that's just for mice. Maybe add on to that, Dr. Z, I could think of a few, but, for humans, right? Like what would be that kind of quality of that time, right? Instead of just,
Yeah.
right.
Actually, we just submitted for publication a publication specifically looking at quality of life in LDN. So that was just submitted for publication. It was data based on over 1,000 LDN patients. So stay tuned for that. We'll be you're presenting that data once it's officially published. But yeah, I mean, so far, I mean, spoiler alert, it's good. Um, Let's see. One of the side effects of LDN is vivid dreams. It's running what the lowest dose was to have a positive effect. Um, so I mean, just real quick. So usually we start patients at either 1.5 milligrams or zero point 0.5, and that's kind of common clinical practice among clinicians who do LDN. And the reason why you start so low is to kind of reduce the severity of side effects for those people who get it, and then you kind of work your way up. We have some blog articles and things like that on the AgelessRx website if you want to explore that a little bit further. That's a whole lecture all by itself. Um, Another question from Kristen: is it safe to combine rapamycin or other senolytics? Um, what are your thoughts on that? Do you have any thoughts in terms of rapamycin senolytics?
Well, so based on our off-label survey, right? I mean, we noticed that a lot of the participants were actually taking multiple drugs, and some of those were longevity-related drugs, right? So like metformin and et cetera. Again, I don't know what dosages they were at, but I could just explain from my studies that I've seen. Again, this is my studies, is that sometimes if you combine two or three compounds, and there was actually a publication on this, you could actually have an additive effect of lifespan. But you could also have a detrimental effect. So I know some combinations that will cause a lot of weight loss in the mice, and that's actually really detrimental. So, um, yeah, other than animal studies, I'm not too familiar. There's one by like Warren Ladige's group that combined, I think, two compounds or three. I think it was rapamycin and carb. Don't quote me on that, but there's a few out there, at least in animal studies, that show there's an additive
Yeah.
effect.
So I mean, rapamycin in general seems to have, it's not a senolytic per se. It seems to be like a senomorphic, where it puts a
Yeah.
brake on senescence, but doesn't necessarily kill the senescent cells.
I don't know. I'm not sure about the
Yeah,
data. Yeah.
yeah, I think the whole area of senescence and kind of targeting senescent cells is still in its infancy. There seems to be mixed results with senolytics. So
Mhm.
I'm gonna have to pass on that one right now.
Yeah.
Next question. Let's see. Do either me or Dr. An take rapamycin or LDN? I did a recent webinar with Dr. Grossman talking about my regimen, supplements I take, medications I take. Um, I do take rapamycin myself. I've been on it for not quite a year yet. LDN I kind of on and off on. I recently restarted again after we kind of did our quality of life and the deep dive on longevity. So I'm on both. I don't, but then again, disclosure, just because I'm on it doesn't mean it's right for you or you should take it. Everybody needs to kind of, discuss it with their own, healthcare provider, and kind of, be educated enough on don't just take it because Dr. Z take it, for example. Make sure, make sure, you get into that. I don't know, Dr. An, do you want to comment or
Yeah, no,
don't
I mean,
necessarily have to?
so yeah, no, no. So currently I don't take either of them just because I'm not quite at the age yet. And I actually talked to Alan Green about this for a while about kind of, what is the right time to actually take it, especially we talked about lipid markers and but I don't take it now. But I think in a few years I will start taking low dose. Again, again, it'll be a low dose just to titrate myself, but eventually rapamycin would be one of the ones I
Yeah.
would start
Yeah, I would
taking.
not recommend rapamycin to anybody under the age of 40. Some people would
Yeah.
say 50. In our
Right.
Pearl trial, we usually had the cutoff of 50, and even then, some people say 60. So, so there's a bit of a controversy or debate among the longevity community about
Yeah, yeah.
best
I
best
mean, I
rapamycin.
mean, again, if you look at animal studies, if you start rapamycin really early, like mTOR inhibition early, you actually extend their life because you actually shrink, like you actually decrease everything in terms
Yeah.
of size and everything. But again,
And
just
if
because
you're a
Dr.
mouse
Z
living
is
in a lab, that's not bad. But if you're a
right,
human, yeah,
right,
again, that there's a multitude of different reasons why I would not recommend rapamycin for younger
right,
people, unless it's specifically indicated. Like there could be some instances of certain, cancers, for example,
right, exactly.
premature ovarian failure, infertility. There's some ongoing trials. There's a bunch of reasons, but if there's not a particular reason and somebody's just taking it just for the sake of taking it, minimum age would be 40. And I kind of fall into that. I'll be 43 this year. So that's kind of why I was waiting a little bit to take rapamycin. I kind of talked a little bit about that on the webinar with Dr. Grossman, if you want a little bit more about that. See, can you clarify effects on your immune system when taking low-dose rapamycin? Worried about risk skin and lung infection. Wondering if the risk goes away with acclimation. So again, I mean, that's part of the reason why we did the registry, is to kind of answer some of these questions. And we'll have some data as well from our Pearl trial once we kind of finish crunching all the numbers. It seems overall there seems to be a protective effect against viruses. There might be a very slight increase in bacterial infection, but not viral. Viral actually seems to be protective. Bacterial, it seems to be kind of like it didn't reach statistical significance on the survey, so I'm not like overly concerned about it. But yeah, theoretically it could. I don't necessarily know if it's something that somebody can acclimate to. Let's see. Oh boy, we're getting more questions than we have time for, unfortunately. I'm gonna have to look through these and maybe pick a couple more questions. There's a question about sirolimus levels. Are you measuring sirolimus in this periodontal in the
Yes.
rapid trial?
Yeah.
Okay.
Yeah. We'll measure like the half-life of it, but it's a weekly dose we're providing for at least this initial phase. So
Okay.
it's just to see if it hits the trough.
Yeah, and then there's a question about LDN versus rapamycin for osteopenia, osteoporosis. Yes, no. Yeah, there was, I think, a mouse trial on LDN and
Yes.
osteoporosis.
Osteoporosis, osteopenia. So individually, there's scientific kind of mouse studies that show that it improves it. But again, it's individual, not combined, or
Yeah.
again, these are my studies. So
I think there was another question about combining the two. Um,
hmm,
As it is right now, my opinion is I think there'll be some synergy between the two, but we really don't know enough about it. I mean, like I said, I recently started back on LDN after taking a break, and so I take LDN and metformin.
hmm.
Um, I think there could be some synergy between the two, but there's also some people could say that I'm playing with fire, and there could be some downsides to it. I tend to be a lot more optimistic on additive effects. I know people like Brian Kennedy, they say you should never take more than two substances, but I find more often than not, taking multiple actually has beneficial effects more often than not. Let's see. Cycled versus continuous. We're not quite sure. Some people cycle, some people take continuously. Let's see. And there's a question about, is it an antiviral? Like, will it kill herpes virus? I don't think it has direct antiviral effect. Rapamycin is an antifungal. That's what originally developed as, but I don't think it has any direct antiviral effect. I think any effect that it might have on viruses is probably immune related. I mean, it seems to upregulate certain antiviral genes to help you fight viruses better. So maybe in that way it could help. Likewise with LDN. Again, I've heard a lot of anecdotal evidence that people taking LDN for one reason, let's say fibromyalgia or rheumatoid arthritis, they don't get as sick as often. And we actually, I did a webinar with the LDN Research Trust. We have an LDN registry open right now to kind of answer these sorts of questions for LDN. Very similar to the rapamycin registry, but hopefully on a wider scale because there's more people taking LDN than there are rapamycin. Okay, let's see. And then just a quick question about could B12 or lysine deficiency cause canker sores with rapamycin? Um, I'm not familiar with rapamycin causing depletion or deficiency of either B12 or lysine or any other amino acids or nutrients for that matter. Um, so I don't think there's a link. Besides, I mean, the timing just doesn't fit. I mean, most people who get cancer sore usually they get it like right after the first dose. So that wouldn't be nearly enough time to deplete somebody of B12 or lysine or any nutrients for that matter. Um,
Yeah, it's an interesting question. I mean, hopefully in a few months, I mean, we're testing a panel of different markers as we're going through the rapamycin in addition to kind of vitamin levels, vitamin D levels. And so, I mean, we'll know if there's an impact, but I agree with you. The timing just doesn't seem to fit, but I just don't know.
Okay, and then so I'm going to take two more questions, and then we can end. One is does rapamycin help anxiety? Funny enough, I think the survey that the rapamycin survey showed that actually people had improved mood, or at least they reported an improved mood. We don't have the data yet on Pearl or any other larger data sets, but they're specifically anxiety. I don't know. Again, thinking about kind of some mood issues are driven by brain inflammation, and there's some thought that rapamycin might decrease that. There could be some benefit for anxiety, but again, that's just
Yeah.
speculative.
Yeah. Anecdotally, all the people I met on rapamycin are nice. Maybe one or two are just kind of out there, but they've always been like that before. So
Yeah, well, that might be more a personality issue than just kind of like
yeah.
diagnosed,
Yeah.
general anxiety disorder. All right, and then last question by our own Garish here. What do you think is the mechanism of action for rapamycin addressing periodontal disease, inflammation, oral microbiome?
Yeah, no, so this is, I think, where I'm really excited. I think it actually targets everything because it all boils down to the biology of aging, right? So if mTOR gets inhibited, you actually improve lifespan because you're targeting that biological process. So I think so far with periodontal disease, we've been only focusing on one thing, like the microbiome, for example. We don't even focus on the other underlying biological changes with whether it's senescence, whether it's autophagy, right? Some of those hallmarks. So I think its potential active mechanism is actually targeting the biological process. And that's why something like periodontal disease improves because it actually does everything, which fits in with the geroscience hypothesis. So yeah, we're very excited to actually start this and just to kind of see. But we've seen it in mice already, some evidence in non-human primates. So yeah,
Yeah, for microbiome, I mean, my guesses would be, there could be some antifungal activity going on.
absolutely.
Maybe you're
Right.
killing off some of the, there
Yeah.
are beneficial yeast and fungi,
Right.
but I think for the most part, as somebody gets older, I've read
Yeah.
that, things like Candida albicans and, some of the other Candida
Mhm.
species and other
Yeah.
fungal species increase. And those are
Right.
that's not necessarily a good thing. That's associated with poor microbiome
Yep.
association. So,
Yeah.
so,
Yeah.
so part of it could be a direct antifungal. I don't think that's the whole story though.
No, no, and the rapamycin, unless you're locally delivering it inside the mouth and painting it around, it won't have a local effect. Many of them will be systemic, which I think is also that kind of the systemic oral health connection we were talking about. Is that it potentially could be driven by the immune function, and that alters kind of the fungal levels and the microbiome levels.
Yep.
But we
Yeah.
we just need to do the trial. Yeah.
Yeah, I mean, there's definitely a synergistic effect between our microbiome and our gut and our body in general. I think we respond to what they provide, and they respond to what we provide. So the thought is that if a person has an inflamed gut, or has some kind of inflammation going on, then then you create much harsher conditions, and so you end up getting bacteria and fungal and things like that are
Mhm.
not favorable for health because you've created a harsh condition. So
Right.
there's definitely a two-way street. So it's entirely possible that by reducing inflammation, you could make the body more hospitable to more
Mhm.
beneficial organisms.
Mhm.
And so you're giving off better signals, more youthful signals, and therefore
Right.
attracting,
Right.
and more youthful looking microbiome, if there's such a thing. I'm just kind of
Right.
making some of these
Right.
terms up.
Yeah.
Anyway,
Yeah. Yeah.
yeah, thank you very much for having us.
Of course.
And
Yeah.
we'd love to have you again. Talk about the LDN mouse trial.
Mhm.
And then we've got so many other things we could talk about in the future. So thanks again, and we'll be
Yeah, of
looking
course.
out. Look out for an email from us in the near future about participating in the dental kind of the dental records registry for people on rapamycin. Okay, all right, thank you very much. That's a wrap.
Thank you.